absolutely have a change in your vital signs. And I'm sorry, as the bedside nurse, I will unequivocally say, yes, I will notice an increase in heart rate. And sometimes I give them a little morphine and that comes down. So don't tell me that's not from pain. Squirming, jerking, body tensing, inability to console the patient, difficulty sleeping or resting or withdrawing from the painful stimuli. I wanted to put this slide in to just briefly talk about propofol. We don't often use Versed. Typically when we use Versed, we do a Versed-fentanyl combination. So we're treating the cognitive portion and we're also treating their pain as well. But in our unit, we love the Michael Jackson drug. We love us some propofol. Problem is, it doesn't treat pain. And although it's supposed to create a surgical amnesia, it doesn't always do that either. And the patient that is here today in 30 is the perfect example of that. He's been zonked on 80 mics per kilo of propofol for days and days and still is able to tell you he's in Ann Arbor Hospital. So that he has some recollection. He has some memories. I've gone into other patients who are on propofol and I took care of them and I go in and I say, do you remember me? And they go, yep. So you don't think that they remember the horrible things that you did to them the day before. Sometimes I don't want them to remember me. So just remember that we need to think first, we need to medicate when necessary, and then we need to perform the procedure. It's not as effective if you're going to do all these horrible things and then medicate. Think first. Bring your morphine in with you, give the morphine, give it a few minutes to work, and then do all the atrocious things that we do to our folks to make them better. Non-medicinal interventions, I know you guys are going to kind of giggle about this a little bit, but I just want you to think about, I learned a lot about these, again, when I worked in labor and delivery. For some reason, nurses in the ICU poo-poo all these. We say that they're unnecessary, they're difficult to obtain. Had a child, had a child, had a child, had a child. Have children, right? What happens when you're over in labor and delivery? They bring in music. They bring in warm washcloths. They give you bouncing balls to sit on. They rub your back. You know what they do? They do all of these. They do all of these. They do the non-medical interventions because a lot of women don't want to be medicated. They want to remember their labor. We can use all those strategies. Guess what? They're proven to work. They're absolutely proven to work. Did you know that over in labor and delivery that there's an 80% decreased need for an epidural by having a trusted female at the bedside during birth? So, but yet we come in and we kick family members out of the room all the time. I'm telling you right now, the 18 years that I have spent with my husband, the very best treatment that you could give for me if I was in pain is to allow Pete to be with me. So just kind of think about how you would feel if you were in that patient's spot. Intervention, here are some of our do's. We do want to assess pain when the patient is awake or on sedation holiday. This is the preferable time to do it. We want to anticipate those painful procedures. That's very important. Again, way too frequently, we medicate after and not before. We do want to pre-medicate. Would you ever do a trach without giving them fentanyl? Would you ever put in a PEG tube without giving them fentanyl? Absolutely not. And we'll get to an interesting slide, I believe it's after this, that is going to surprise you of what the most reported painful procedure is. We do want to try to define the pain level as much as we can, and we need to document. We need to monitor their vital signs before and after getting treatment. If anybody ever wants to do a really cool study, I bet you could debunk some of the bad myths that are out there that say that vital signs don't correlate. We want to reassess. You do need to reassess. There is very specific policies that speak to this in our institution. It's 15 minutes after IV and 1 hour after oral. Otherwise, how do we know that it worked? Morphine doesn't work for everybody. Does not treat my pain, it just makes me throw up, which is in turn going to make me feel worse, right? We want to document our follow-up score on our flow sheet, and we definitely want to offer those non-narcotic interventions along with the narcotics, especially true in our ICU. We give sneezes of medication compared to the other ICUs. Sneezes. We give 2 milligrams of morphine every 4 hours. How often have you guys seen that order? I don't know what the heck is that. Be consistent and think ahead. Don'ts. We need to not make judgments or assumptions about pain. A neurological assessment does not hurt you. But let me guess, if I put one of you guys in that bed right now and tie you down and stick a tube in your throat and stick a tube up every single orifice that you own and then come in and start pinching you at 7 o'clock in the morning, I think you're gonna have a little bit different opinion about what is painful. Please don't forget that pain is subjective, and what I can tolerate is very, very different than what other people can tolerate. If my husband would have had to give birth to a child, he probably would have stroked. Like, there's no way he could have ended that. But on the flip side, he's also almost cut off all of his fingers and, you know, pretty much drove himself to the emergency room. So it's different levels of what we consider painful. Do not replace effective pain management strategies with sedation. Sedation is not analgesia. Remember that. Just keep saying it over and over in your head. It's not. Do not forget to reassess and document all new pain scores on your 24-hour flow sheet. This is super important, you guys. You can document, or I mean, you can treat pain till the cows come home, but all you need to do is find yourself in court once with somebody saying that they didn't give me anything. Or even scarier, you didn't document anything, and now they're saying, well, why are you taking out all of these narcotics? If your patient doesn't have pain, and you took out 17 Vicodin in 2 days, you just don't work here anymore. Okay? Document, document, document. So, building on that, we all know pain. We all recognize that this is a critical care setting. We recognize that we do a lot of horrible things to our patients in order to get them out of here. It's bad. Horrible treatments for improved outcomes. I bet that would be an interesting study. But all the narcotics that we give cause side effects. Nausea, vomiting, bleh. There are certain medications that we are allowed to give in our ICU and certain that you really should stay away from. Some medications, such as Compazine, can decrease the seizure threshold, which is why we don't give it any longer. Phenergan, I think, was one of them, too. We used to give a lot, and we don't give that as well. Zofran, Benadryl, but please use Benadryl with caution. Again, it can decrease the seizure threshold, so you gotta be very careful on that. And dexamethasone, surprisingly, sometimes can help for nausea and vomiting. If it's anesthesia related, I can give you a little trick, and it does often work, is to take an alcohol swab and rub it on their nose. It's an anesthesia trick, and it does work to decrease nausea. Cooling the room can help with nausea as well. Constipation. Everybody that works or have worked on 4A will yell at the ICU nurses and say we don't ever make our patients poop. So we do have to be cognizant that when we give them narcotics, we are slowing down the gut and we are putting them at risk for constipation. So make sure we keep up on the senna, the colies, the milk of mag, and so forth. And some people have allergies. Again, Benadryl is an option, but maybe you want to think about topical or a topical steroid, things like that. Benadryl really can cause respiratory compromise, vital sign compromise, mental status changes, hallucinations. So just be aware, as well as all the narcotics can do those things, that you have Narcan at your disposal if you think that that's what's causing it. One of the slides is missing, I think. If I don't, it might have skipped over. If not, I'll tell you guys what the most painful procedure is, surprisingly. So, documentation for oral. Again, you need to document what the pain score is prior to giving the medication. You need to document within 1 hour of giving the medication. That is University of Michigan policy. That's the reassessment. You need to document prior to discharge for patients that are being sent home. And if a patient is sleeping at the time that you should be assessing it, is completely appropriate to write patient sleeping and a patient's respiratory rate in place of the pain score. And this is right off of our documentation website. IV, if there is pain present and is treated with IV, as needed opioids, the pain should be assessed and documented as followed. At the time, of course prior, at the time of IV medication administration, a pain score, sedation level, respiratory rate, and oxygen stats are all assessed. Very frequently we go in there and we just go, just give them some morphine, little fentanyl, because we're so used to it. We don't even think about it anymore. But narcotics are dangerous, and I don't know if any of you guys ever worked on the floor, but I do remember on 4A there were some nurses that were very fearful because of things that had happened, and they would hang 2 milligrams of morphine over 15 to 20 minutes. So bad things can happen, and if you've never given that medication to that patient before, how do you know? So within 15 to 30 minutes after IV administration, yes, on centricity you have to create a new column, but you should be documenting a reassessment of the pain score, what drug you gave, sedation level, respiratory rate, and oxygen saturation. If a patient is stable after 15 to 30 minutes of giving that medication, then you can go back to your normal